Welcome back to Eye on Health
on DubaiEye 103.8
with MedLab Middle East.
We're talking about conditions in pregnancy that women and indeed their partners need to be aware of. And as diabetes in pregnancy grows more common, experts are pointing to a need for preventative care. Gestational diabetes is on the rise, climbing 30% between 2016 and 2020, according to a new study published by the Centres of Disease Control and Prevention. This means that diabetic women who would like to become pregnant face several hurdles during their journey. To find out about this and more, we're joined now by Dr. Koulshan Mohammad Jameel, a specialist obstetrician gynecology from the Canadian Specialist Hospital. Doctor, thank you for making time for us. I know you're very busy and you've got some very important little patients coming into the world. So thank you for really shining a light on a very important topic globally, but also especially in the region where we have got such a prevalence of diabetes. What are some of the major challenges or concerns that women need to be aware of if they have diabetes, pre-existing diabetes, and want to become pregnant or are pregnant?
Good afternoon, and thank you for giving me this opportunity to discuss this very important subject during pregnancy. As you mentioned, it might be pre-existing or gestational. If both are well controlled, there will be no concern. The outcome, it will be like normal pregnancy. But the problem is when we enter pregnancy with pre-existing diabetes is uncontrolled. If uncontrolled, there will be increased chance of infertility, recurrent miscarriage, stillbirth, and birth defect. This complication will not be present with gestational diabetes because gestational diabetes will occur later at 24, 28 weeks when the baby is already grown and the organs is developed. So there will be no concern of this complication. There will be other complication will occur throughout the pregnancy. The other challenge is in gestational diabetes is diagnosis because the symptoms is mimic normal pregnancy. So the main concern, we have to be aware of the symptoms and do screening program, at least for the high-risk women. High-risk women, the one who is more than 35 years, 25 BMI, certain ethnic group like Asian, African, or Native American. At the same time, the woman who had gestational diabetes before, or she gave birth of the baby more than 4.5 kg, or she had family history of diabetes. So it's a clinic broker. Yeah.
Let's go back to pre-existing diabetes, and then we can talk a little bit more about gestational. So if you do have type 1 or type 2 diabetes, am I correct in understanding what you're saying there, that you might have more problems getting pregnant and staying pregnant and having a healthy birth? Is that right?
Yeah, you are right. If it is controlled, the complication is negligible, but this is not controlled, there will be increased chance of all the complications. The complication will be maternal or fetal.
I think for many people, there's an awful lot of people who simply don't know if they do have diabetes. You know, a lot of people who might be pre-diabetic and not understanding, therefore they're not getting the support, they're not living a life where that condition is controlled. So it might be interesting to be raising awareness of diabetes in general in women to make sure that they're taking control of their health before starting on that family journey. So let's say you do have a patient who has type 1 or type 2, it is controlled. And I think it's really important to come back to your point there, that if you are under good care and you're looking after your body, the complications, in your word, are negligible. You know, it's you're going to be working closely with your healthcare provider. But if it's not controlled, then there could be some risk factors. Are you more likely to have a bigger baby if you have diabetes?
Sure. There will be a complication because of the high blood sugar of the mother, and which is transferred to the baby through the placenta. And there will be more glucose and more insulin secreted by the fetus will increase size of the fetus. And increasing size of the fetus, it will be effect on the mother and the fetus, especially at the time of delivery. There will be traumatic to the mother, the genital tract, and traumatic to the baby. Especially at the time of the delivery, if it is normal delivery, it might be trauma, especially at the shoulder after delivery of the head. It can cause trauma to the brachial plexus, the nerve plexus underarm, which cause Erb's palsy and lifelong defect paralysis of the upper arm.
And what about health of a baby after it's been born? Are there any potential complications beyond, I guess, the physical during delivery, for example?
Sure, there is a lot of complication, especially if it's not controlled. The first complication will be hypoglycemia, because the source of the high glucose already removed at the maternal circulation. So baby prone to the hypoglycemia, hypocalcemia, hypomagnesemia, even hypothermia because of the wide surface area. At the same time, possible conversion because of this decrease of these elements. And also respiratory distress syndrome, that difficulty on respiration because of the lack of the surfactant, and they might need to enter the admission to the high dependency unit or NICU department. And later on, they are most liable to have hyperbilirubinemia that increase neonatal jaundice. In the childhood, they are liable to the obesity, and the future, they are liable to the type 2 diabetes.
So it's not just the impact on them as a baby. As you're saying, there could be a greater increase of chance of developing diabetes or obesity later in life. So having your diabetes under control during your pregnancy and then obviously continuing that care after, which is such a difficult time for new mums, you know, that fourth trimester of trying to stay on top of having a new life on the home, but really prioritising their own health is absolutely crucial. Can we come back to gestational diabetes, which, as you say, is screened for during pregnancy around that 24-week mark? Can you tell us a little bit about the testing? I remember a particularly unpleasant bottle of orange juice in the clinic that I had. Yeah. Is that still the case?
Yeah, right. First, we will do fasting blood sugar. If it is normal or borderline, we might go to the glucose challenge test. As you mentioned, there is unpleasant solution. They will take it. They don't like it usually. Certain amount, 50 milligram, and we check blood sugar after 1 hour. And if there is any suspicion, we might go to the more prolonged test that will be 75 or 100 gram of the glucose. They will be checking first hour, second hour, third hour. And according to the schedule, we diagnose her as gestational diabetes.
And upon that diagnosis, what is going to change in the day-to-day life of that mum-to-be? What is she going to be doing and not doing to manage that condition during her pregnancy?
While if we diagnose diabetes, the management will be multidisciplinary. It should be patient, family, specialist midwife, obstetrician, dietitian, and physician should be involved. Regarding the patient, should be compliant to the plan, monitoring glucose at home, and the family, they should be supportive and encourage her to follow the plan. Dietitian, she will follow with her how she will take her meals, how she should not skip any meal, snacks, how to avoid more carbohydrate or artificial sugar, and her breakfast should be before 9 o'clock, and the last dinner should be less before 8 p.m. And exercise, so to utilize what accessory calories she's gaining. Mm-hmm. If it is controlled, it's fair enough. If it's not controlled, we will take opinion of the physician to go to the medical management, either hypoglycemic drugs, or oral hypoglycemic, or the golden rule is the insulin therapy. Then it will come the rule of the obstetrician, close follow-up and close observation of the fetal monitoring, fetal weight, growth, amount of liquor, lie of the fetus, and the time of the delivery.
And doctor, what correlation is there between maternal weight gain during pregnancy and the chance of developing gestational diabetes?
This is one of the risk factors, as we mentioned. If the body mass index is more than 25, she is prone to diabetes. But if she is gaining more weight during pregnancy, increased chance of the diabetes and hypertension during pregnancy.
And then what happens after delivery? You're given a diagnosis of gestational diabetes, you're working with the team, you, inshallah, have a happy, healthy baby. What happens next? Does it simply go away after delivery, or is there anything the mother needs to do after?
Of course, no. We have to follow her. If she's pre-existing diabetes, she will go back to the same medication or same regimen to have pre-pregnancy. and she follow with her physician. If she is gestational diabetes, we will follow her sugar after delivery. Usually it will go to normal because the source of the counteracting insulin source, that's human placental lactogen, is already removed from the body. So we follow her next visit at 6 weeks to check blood sugar. If it's normal, we advise her to check every year to avoid, to control, because she's more liable to get type 2 diabetes in the future.
And as you said earlier, in terms of risk factors of gestational diabetes, if you had it during a previous pregnancy, you've got an increased chance of having it in a subsequent pregnancy?
Sure. If she had previous gestational diabetes, she had more liable to get it in the future and more liable to get type 2 diabetes in the later in life.
Doctor, my last question to you is for anyone who is diabetic, any woman that's diabetic and is hoping to start a family or have another child, what advice would you give to them?
First of all, she had to check her blood sugar. She's controlled. She had to check collective sugar of last 3 months, like HbA1c. It should be within normal limit. We advise folic acid as the WHO rule to decrease chance of the birth defect. And her weight should be ideal, and exercise, and go on.
So good common sense, and a doctor that you know, like and trust, who can work closely. Doctor, thank you so much for your insights today. Run out of time, unfortunately, and I'm sure you've got plenty to be getting on with there at the Canadian Specialist Hospital. Dr. Koulshan Mohammad Jameel joining us, a specialist in obstetrics and gynecology. Thank you so much for your time.
More with Eye on Health next on Dubai Eye 103.8.